Hi, I'm Michael York of the section of Rheumatology. I'm speaking today on behalf of the physicians of the Lupus Clinic, which include Dr. Hani Men-Josefi of Nephrology, Dr. Christina Lamb of Dermatology, and Dr. Monica Crespo-Bosque, also from Rheumatology. Our project that we're talking about today is to look at the different factors involved in why our lupus patients miss appointments more frequently than those with other connective tissue diseases. For this, we worked with my co-speaker today, Lauren Betancourt, MPH, a Senior Program Manager for Quality and Performance Improvement of the BU CME Department. Lauren and I will speak, but the other members of the team are present for any questions after the talk. Next slide, please. As many of you know, lupus is an autoimmune disease that affects women 10 times as more frequently than men and usually occurs during the childbearing years. This is very similar to other connective tissue diseases that we see in rheumatology, but lupus has well-established increased risk of more severe disease in certain ethnic populations, such as those of African descent, and several studies have shown that Black, Asian Pacific Islander, and Hispanic lupus patients have more kidney, neurological, and blood manifestations and worse outcomes compared to whites. In addition, as this slide shows, that even when adjusting for racial and ethnic factors, there's still increased prevalence for lupus in areas of lower socioeconomic class, and the reasons for this is not well understood. Lupus patients frequently have higher rates of non-adherence to visits and medications, and this correlates with worse clinical outcomes. We developed the Lupus Clinic here at BMC to optimize coordination of care of these patients by arranging for 3 specialist visits at once. The patient would be seen by a nephrologist, a dermatologist, and a rheumatologist during the same visit. However, we still had a higher rate of no-shows and same-day cancellations in lupus patients compared to our other diseases that we see in rheumatology. And this has been shown in multiple other studies as well. For that reason, we reached out to Lauren to help us with a quality improvement project to improve visit adherence and to find out the factors behind this. I'm going to hand it over to Lauren now to review our data. Next slide, please.
Thanks, Mike. So to more fully understand the disparities that hindered access to care for BMC patients, Boston Medical Center patients specifically with lupus, we did initiate a QI project and began to perform a formal current state assessment, which you can see summarized on this slide. So to articulate the impact of each variable, we acquired available data through EPIC and patient interviews. And to understand how we stratify this data and developed conclusions, it's important to note that we define patient access in terms of visit compliance, or the ability of a patient to attend their visit as scheduled. And we define significant correlation as a greater than 5% difference in compliance rates when compared against attributes in the same category. So after diving into these attributes, we found that the lupus patient population level demographics were not consistent with the overall patient population trends from all 3 clinics, nephrology, rheumatology, and dermatology. We found only significant correlations between patient age, insurance type, and seasonality. Seasonality was actually expected due to the photosensitivity brought upon by this disease state. So our takeaway from this robust analysis was that the intervention we designed needed to be patient-centric rather than centered on a single demographic criteria. Next slide, please. So the graph you see here is a P chart. It's a control chart that represents visit non-compliance between October of 2018 through February of 2020. We observed an average for non-compliance at baseline to be just below 20% for patients with lupus, accessing all visits in nephrology, dermatology, and rheumatology. So for outliers exceeding past the control lines, this is an indication of special cause variation that I will point out in more significance in just a minute. So with our understanding of what baseline meant for us and a grasp on the contributory factors driving these access issues, we set an aim to reduce visit noncompliance by 5% per month in 2020 as compared to the same month in 2019 as to control for seasonal variation. So we began by adapting an intervention that actually was successful in cardiology at Boston Medical Center for CHF patients that included an open-ended script for speaking with patients before their visits. So we adapted this script and applied different variables to discuss with patients in advance. So the patient navigator and nephrology began contacting patients in January of 2020, 3 days prior to their multidisciplinary visit, to query about needs understood through patient interviews related to transportation, directions to clinic, PT1 access for patients that were Medicaid eligible, and information regarding the importance of appointment compliance when the patients were feeling well, and visit compliance as requisite for maintaining their maintenance medications. So after observing special cause variation related to our aim, in the last 2 months, as pointed out in the slide, we analyzed responses from patients and concluded that this script or proactive inquiry into the attributes of the visit with select barriers to appointment access was successful in preparing patients with lupus for upcoming appointments. Next slide, please. So in sum, we seek to dive into considerations for adapting this intervention with respect to the evolving telehealth landscape. However, we have not fully dove in just yet to the attributes that we need to consider for adaptation. Thank you.